Good afternoon, everyone. And good afternoon and welcome to all the people joining us remotely over the web as well. So we'll be starting the session in a few minutes after I introduce all our guests. So how many of you have joined the previous talk 2 days ago on Friday? Good, thank you. And some of you are very new, okay, fine. So let me introduce our team from Stanford. We have Dr. Peter Acker. And we have Dr. Patrick Lanter, another round of applause. And we also have Dr. Enoch Oben, for those who have 2 days ago, who delivered an excellent talk. Right? Today, Dr. Peter as well as Dr. Patrick are going to speak about the future, the present and future of emergency care. Dr. Peter is an associate professor of emergency medicine in the University of Stanford, and global health is his expertise. And Dr. Patrick is a clinical instructor of emergency medicine and is a board certified emergency physician as well. And global health, along with doing ultrasound in emergency department, is our RS core skills. So they are going to speak about the emergency care today and in the future as well, right? I also welcome Dr. Raman Rao sir, the Director of Emergency Medicine and Learning Center, Dr. Rajnath Singh Rao sir, and our instructors, and obviously you guys as well. तो अभी मैं ये बोल रहा था कि हमारे जो गेस्ट है आज बात करने वाले हैं इमरजेंसी केयर आज कैसा है और कल फ्यूचर में कैसा रहेगा इमरजेंसी केयर आज और फ्यूचर में कैसा रहेगा इसके बारे में बात करने वाले हैं ठीक है तो first 45 minutes will be the talk and last 10 to 15 minutes if you have any questions you can ask the questions and then we can get some answers from our guests. Is that okay? For people listening to us online, if you have any questions, please type in the comments box and we'll ask the questions for you guys. Okay, thank you. So now I invite Dr. Peter to start the session.
Is there a microphone? Just go. Okay. Good afternoon. How is everyone doing? So I wanted to first see who's here in the audience. So if you're an EMT or EMT student, raise your hand. All right, so a big crowd of EMTs. What about paramedic or paramedic students? All right. And then what about instructors? A small group of instructors. And then we have some of our visiting faculty, the leadership. Well, thank you all for being here. It's really wonderful to get to speak with you. My name, as Dr. Apoorva mentioned, is Peter Acker. I practice emergency medicine in the US, and I'll be presenting along with my colleague, Dr. Lanter, what we think emergency care looks like, not only today, but in the future. I'll be presenting some of the general material, and Dr. Lanter, who is an ultrasound expert, will be providing some insights about ultrasound. Sound good? All right. In the future, PowerPoint will work seamlessly, but not yet. So what we'll talk about a little bit today is how technology is likely going to change the way we provide. And I think that it's going to help enable us to provide higher quality care and broader access to care for patients who are experiencing emergencies. So we're going to look at the role that technology can play through of cardiac arrest. With a show of hands, has anyone here taken care of a patient who had cardiac arrest? I imagine at some point in your career, you will. And I think we'll try and demonstrate what the current state is, and then hopefully what we can attain in the future. But cardiac arrest really is the ultimate emergency. It requires the whole emergency care system to work perfectly in order for people to survive. And without really timely intervention, the mortality can be really high. So this is something that we all need to care about. EMTs, paramedics, hospital providers, in order to try and optimize outcomes. So for someone to survive a cardiac arrest, when their heart has stopped beating effectively, a number of things all need to happen. In order for this to work, first of all, someone has to recognize that that patient is in cardiac arrest. Without that, we can't provide care for them. Once it's recognized, they need CPR. Has received CPR training. Some of you, those who have not yet, I'm sure that you will during your training. So you'll learn how to provide care for patients who have cardiac arrest. Another key intervention is defibrillation. So if somebody's heart isn't beating effectively, restarting it with electricity can help save their life. But you have to do that quickly. The next component is efficient emergency medical services activation. So your job, getting to these patients to provide them with quality care and bringing them to a hospital where they can receive advanced resuscitation. And if they survive all those steps, they need really good care after resuscitation to live. So you can see it's a complicated disease process and all these pieces need to work. Because it's so complex, the morbidity and mortality is high. So it's not entirely uncommon. And in India, there's a lot of cases every year. Unfortunately, the survival rate is not very good. It's about 10%. And so 90%, 9 out of 10 people who have cardiac arrest, unfortunately die. And things have gotten better. So on this graph here, it shows the percent of people who have cardiac arrest that survive over time. So as you can see, between maybe 2000 and 2010, things got better. But really, things have plateaued between 2010 and 2020. And we need to think, how can we continue to progress? And why is this happening? So let's look more closely. So here's all the things that I mentioned are required for survival. The first being early recognition. The challenge is that more than 50% of cardiac arrests are unwitnessed. So people have this challenge at home or in the field, and no one sees them, so we can never provide care for them. We can't help patients that we're never aware of. So that half of the patients, we never even have a chance to help. Then prompt CPR is really important. But of those that are recognized, only about 9%, so about 1 in 10 patients gets bystander CPR. So that means they're waiting for a long period for someone like you to come provide CPR. And during that time, their brain and their heart are suffering. The next intervention is rapid defibrillation, restarting the heart. And unfortunately, only about 8% of patients that have out-of-hospital cardiac arrest ever have an AED, a defibrillator, placed on them. And of those that do, it usually takes more than 8 minutes. And so when someone's heart is not beating, all of that time is precious for their brain and their heart and their other organs. So when those first few steps aren't happening, the last couple, EMS activation, advanced resuscitation, post-resuscitation care, they're less important. That key window at the beginning of early recognition, early CPR, and defibrillation are the most important. So until we make those better, it's going to be hard to improve outcomes from cardiac arrest. But I want to share with you a couple of exciting opportunities that technology can help us do better. Some of these solutions can help us provide early recognition, more prompt and even better CPR, faster defibrillation, some targeted use of emergency medical systems like yourselves, and more effective advanced resuscitation care. And we'll also touch on a couple of other areas where technology can potentially really help. So we're going to start with, how do we improve our detection of emergencies like cardiac arrest? So the first cool example is wearable technology. So many people in this era have a watch that helps detect their heartbeat, maybe detects how far they're walking. More and more commonly, people are wearing this technology. And these types of technologies, these smartwatches, often are starting to be able to detect things like ventricular tachycardia. So this could improve our ability to witness a cardiac arrest. Even if you're alone, if you have a device like this, it could alert the medical system that you need help. So this might give us the chance to identify patients in cardiac arrest, even if they're by themselves in a place where we can't see them. They're also reasonably good at detecting other arrhythmias. So for your jobs, those of you who work in hospitals, this can be quite a helpful tool for people who have atrial fibrillation. And as we go forward, I imagine will be applied to many other scenarios. There's better and better personal ECG technology. So now there are devices that patients can put them on themselves, or a family member can apply, or a pre-hospital care provider can apply, that are both wireless and portable. They take no training to apply, and they can really complement a lot of the services that EMRI is already providing, like telehealth, some of the field triage decisions, and some of the directions medicines going, like hospital at home. The other technology I want to mention was smart speakers. So who here has seen either a phone that you can command with your voice or has a smart speaker? Has anyone ever had? Does your phone have Siri or something like that? It's more and more common. I think the most recent data from the US says that about 75% of homes have some device that can listen to your speech. And there's been some fascinating work looking at detection of cardiac arrest using just the audio function of a smart speaker or a smartphone. What they did is they realized that when you're having a cardiac arrest, your breathing changes. And the researchers trained the smart speaker to differentiate between agonal breathing during cardiac arrest and other types of breathing, like central apnea, obstructive apnea. And it turned out the smart speaker was very good at determining when someone was having apneic or agonal breathing due to cardiac arrest. So you can imagine a scenario where your smart speaker could hear you having this respiratory difficulty and call an ambulance to come get help, even though no one was there to notice that you were sick. So the numbers were pretty good. They're 97% sensitivity, 99% specificity, which is really pretty impressive. I think this is yet another instance where technology could help us identify people who need care, even when we're not able to without it. So the next phase I wanted to think about was, how do you decrease time to quality care? So as we noticed many times, these were unwitnessed. When they were witnessed, people weren't often getting bystander CPR, and defibrillation was slow. So can you think of any barriers to CPR, particularly in your work here? Like, why don't people get CPR? Any thoughts? I think unwitnessed, someone said, absolutely. If you don't see someone who needs CPR, you can never give it to them. Are there other thoughts from the audience? Lack of awareness. Like awareness, sure. Maybe people haven't been trained, and I think that's a big barrier.
People wait for the emergency technician to come.
Say that one more time.
People wait for the emergency technician to come and do the work.
Sure. So maybe waiting for additional help. Absolutely. And I know your team here is doing a lot to help increase the knowledge of CPR skills in the community. I think sometimes there's, I think all those things play a role. I think one of the barriers that technology is helping address is helping those who do have CPR training to identify those who need CPR. And so I understand recently there was a large CPR training here. Now all of those citizens are living in Hyderabad, going about their days. The challenge is many times when someone needs CPR, they're not near someone who can provide CPR. There have been some very interesting cell phone apps that now can identify people who need CPR, usually through, say, like a 108 type of service or 911. They can then send a notification to all registered CPR providers using the app that can tell you someone near you needs CPR, and they can give you a map, they can give you directions, and they can guide you to the person who needs CPR while you're waiting for an ambulance to come. So you can imagine in many scenarios, this would help decrease the time to CPR by providing links with a trained care provider. There's been pretty good data that suggests that these apps actually do increase the rates of bystander CPR, so helping decrease that duration without chest compressions. They've been able to decrease the response times, and it's actually now written into the American Heart Association guidelines that these are functional and recommended apps. They can also help improve the quality of CPR. So this app, you can see in the bottom, can give step-by-step instructions, either read or audio, that can help teach you to do good CPR, even if you're not intimately familiar. So if you use these apps, they can not only tell you when someone needs it, but they can help you do it better. So what are some barriers to early defibrillation? So why is there such a delay in defibrillation, and why doesn't it happen more commonly? Yeah, so people don't have AEDs, they're expensive, they're not everywhere. I think that's a huge barrier. People might not know how to use them, absolutely. So I would be nervous to defibrillate someone if I didn't know how to do it. And so I think that access is a huge issue. I think that they're too expensive, and I think that they're just not that common right now. So there's been a couple of interesting developments to help with that. One is helping people find AEDs that exist in the world. So similar apps now are including registries of AEDs, so that if someone has an AED, like say here on campus, you can register it and show exactly where it is. So if someone has a cardiac arrest, the app can direct someone to that AED so they can get it and bring it to the patient. So that's a very handy function. And at least in simulation studies, this has done a pretty good job of decreasing time to use of an AED. Along the same lines, there's some pretty cool applications that use augmented reality to actually allow someone to scan with their phone and find AEDs in the real world. So although this is still in development, I think it's a neat idea and just illustrates that we need to do a better job at connecting people like yourselves that have training to the devices in the community so you can use them. I think one area that seems promising is there's been good studies looking at drone AED delivery. So I know this sounds very futuristic, but I think may not be that far off. So instead of explaining it, I'm going to play the video for you. If I can. So here this is made by the company that produces the drones, but it's demonstrating someone in their home who's realized that their loved one is unresponsive, having cardiac arrest. And they run to their phone, dial 108 or 911, and then the dispatch center hears the complaint and immediately launches the drone loaded with an AED at the local airport. And there's been some studies to look at, like, does this work? That sounds neat, but does it work? And in the initial studies, they found they could pretty consistently deliver the AED within about 9 meters of the call site, so quite close. And then it reduces time to AED delivery faster than an ambulance. And in urban settings saved about 2 minutes, which is not a lot. I'll be honest. I do think that could be an important difference. If somebody is waiting an additional 2 minutes for defibrillation, I feel like that could be important. But what I think is more important is think about that difference in a rural environment where, or an environment like India where traffic can at times be very challenging to navigate, that maybe that would be even more significant. So I think there's a lot more to learn there, but I think it's a creative use of technology that may help us deliver better care going forward. So perhaps one day you'll be training to be drone pilots instead of EMTs. So the next piece I want to talk about is how can technology help us provide improved resuscitation? And we'll look at a few different applications. So I think the first interesting instance is using AI to help interpret ECGs. And so there's a lot of really interesting ways that deep learning can evaluate ECGs and find patterns that us as humans can't. They can help link underlying pathology and find new ECG patterns that relate to the pathology. They can help with basic interpretation, and they can also help with difficult ECG patterns. Sometimes we struggle to determine the difference between SVT and ventricular tachycardia, and the computer is getting better at making those differentiations in ways that sometimes we struggle with. I think is an exciting new application. I think the next really exciting potential is extracorporeal CPR. So we were just talking about CPR, which is a critical element of cardiac arrest management. One of the new potential arenas for improvement is extracorporeal CPR. And what that means is in someone whose heart is not beating effectively, basically doing the work of the heart with a circuit called ECMO, which is extracorporeal membrane oxygenation. And what that does in someone whose heart is not beating is it takes blood out of their body, it pumps oxygen in the blood, and then it pushes the blood back into the body and provides a blood pressure. So that blood can circulate to the heart, can circulate to the brain, the kidneys, the lungs. So it allows a person to survive many times, even though their heart is not pumping or pumping effectively. And there's been some studies to figure out, is this helpful? Could this help patients in cardiac arrest? And though the data is early, there are some studies that show that it may in fact help people live and live with better brain function after cardiac arrest. However, it does require a lot of other resources to support this. This isn't an intervention necessarily all by itself. Many of these patients also get catheterization with a cardiologist and very good post-resuscitation care. And they're also pretty stringent about who they resuscitated, which I think helped them improve their outcomes. But it's something that's being considered for patients who have an out-of-hospital cardiac arrest, are between the ages of 18 and 75, and have an initial heart rhythm of ventricular tachycardia or ventricular fibrillation, who are not able to maintain spontaneous circulation. So even though you're giving them shocks and all the right medicines, their heart will not restart all by itself. The other key piece is that this only really works if it's done quickly. So these are for patients who can receive care, usually less than 30 minutes, and can be placed on this eCPR device in less than 1 hour. So it's pretty tough to do these things, but for people who might fit those categories, it could be helpful. And we've actually started setting up a system like this for our own hospital. So for patients who have a cardiac arrest and fit these considerations in the lower left-hand corner, they're reasonably young. They have a witnessed cardiac arrest or an initial rhythm, that's ventricular fibrillation or ventricular tachycardia, and have a limited amount of time without CPR. So again, the big challenge is making sure people get CPR as quickly as possible, and that we can start this eCPR within about 60 minutes. So it's something that's becoming more common. But one of the keys is, again, we need to start these therapies quickly. These things all are time dependent. The longer someone has poor blood flow to their brain, the more likely it is their brain's not going to work after the cardiac arrest. So there have been some trials to figure out how do we do these things faster? How can we get these to patients more rapidly? And there's been two ideas. One is, what if we could increase the number of hospitals that could do this? So if a patient can't go to the big hospital where they do this all the time, maybe they go to a different hospital. Could we help all the hospitals do this more frequently? And they've done this through sort of a mobile eCPR team, which I thought was a really cool idea. So when somebody calls the equivalent of 108, that little blue person in the central dispatcher, that person sends an ambulance to go get the patient. And they also send an eCPR team to the hospital that they're going to take the patient to. So it turns any hospital into a hospital where this advanced procedure can be performed. That patient goes to the hospital, gets placed on eCPR, the ECMO, and then goes to the cardiac catheterization lab to see if they have something going on with their heart that the cardiologist can help with. Then they all went to the main hospital, who was really well trained in providing this care, and they went to the ICU there to receive post-resuscitation care. So it helped decrease the amount of time to this therapy. And the results were at least about the same as the results from the initial study, showing that probably taking this team to other hospitals allowed those hospitals to perform about as well as the main hospital that was really experienced with this. So I think an interesting concept. If you take that one step further, if you think that doing this as soon as possible is helpful, maybe doing it out of hospital would be helpful, right? That's the fastest you could get this to someone. So there have been a couple studies looking at eCPR in the field. So this is a picture of an advanced pre-hospital care team placing a patient on ECMO in a subway. You can see the train, you can see on the wall, there's the stop name, it's an advertisement. And so they're trying to figure out, if time is so important, can we reduce that time by taking this care to the patient in the field? The data is still very early, so I don't think this is mainstream yet, but it's an interesting new application that helps you think, what are other ways we could help improve care in a creative manner using this technology? So there's some other amazing technology that I'm going to let my colleague, Dr. Lanter, tell you about, and then we'll pick up after that.
Anyone need a stretch? Stand up, do some jumping jacks. Feel good, power through. All right. So Dr. Acker started preparing this talk about technology and how it's used in cardiac arrest and kind of where that care is going. And a lot of what you've learned about so far is ways to allow effective CPR to be performed sooner. So how can we have people get bystander CPR? How can we get AEDs in the field? How can we connect our emergency services with people who have cardiac arrest in the field? I'm going to kind of pivot off of that and talk about something a little different called transesophageal echocardiogram, which is a form of ultrasound. And rather than helping to get people and resources to a patient faster for CPR, transesophageal echo is a technology that's being used to increase the effectiveness of CPR and make us better at resuscitating patients, so that once you are on scene, once you're taking care of that patient, we can be better at that. So transesophageal echo in the context of cardiac arrest is known as resuscitative transesophageal echocardiogram, or TEE. And it's useful for a lot of different reasons. I'll touch on each of these separately, but just kind of briefly, it allows us to assess for cardiac activity. TEE allows us to decrease the time for pulse check so we can be performing CPR more. It can allow us to evaluate the effectiveness of chest compressions. And we can look for reversible causes of cardiac arrest. And then lastly, as Dr. Acker was talking about, ECMO or eCPR is something that's being used in cardiac arrest now. TEE is actually essential for that process to make sure that the cannulas are placed in the right place. And I'll show you kind of how that works as we move a little farther. So transesophageal echocardiogram allows for rapid assessment of cardiac activity. For a TEE, you place the probe into the esophagus and the transducer sits just behind the left atrium. Because of this, the sonographer can constantly evaluate the heart without the need to utilize valuable real estate on the chest where compressions and defibrillator pads are placed. This diagram here, I don't know if the mouse works. Can you guys see the mouse on there? No, I use this. So the way that this probe is set up is you have kind of the controls of the TE probe right here, and then this long black cord with an ultrasound probe that sits right at the end of it. And you insert the probe into the mouth down through the esophagus so that you're looking at the heart directly from behind the esophagus. And because that probe is sitting in the esophagus rather than on the chest, it never has to move. It can just be sitting, looking at the heart during the entire resuscitation. Because of this, it decreases the time that we need for a pulse check. Whenever you're doing CPR, how long do you have for a pulse check? Or how long do they normally recommend stopping CPR to check for a pulse? 6 seconds, 5 seconds, 10 seconds. I'm kind of hearing a lot of different answers. Would anyone disagree with the statement that less time for a pulse check is better? Yeah. So the reason that TEE is so valuable in these instances is because you don't actually even really have to be feeling the pulse, because a lot of times it can be hard to find where that pulse is. It can be hard to really tell if you're feeling one or not. And they've actually shown that our fingers aren't very good at detecting a pulse. Normally we can get a systolic blood pressure of about 60 in the femoral artery. But, you know, there are people who have a pulse that we're not able to pick up with our fingers. TEE allows us to directly look at the heart during that pulse check to see if there's any organized activity. If the heart's beating, there stands to reason that that patient at least has some forward cardiac output. Whereas if the heart is completely standing still, it doesn't matter if you're going to feel a pulse or not. That heart it's not beating and you need to restart CPR and continue your resuscitation. What I think is probably the most relevant and interesting aspect of transesophageal echo is evaluating for the effectiveness of chest compressions. This is what's called a mid-esophageal long axis view, which is one of the first views that you can obtain with the transesophageal echo. It's one of the first things you'll be able to see as you're evaluating the heart. What we're seeing here is the left atrium, the left ventricle, and then labeled as the left ventricular outflow tract. So notice where this heart is being compressed. Can you see how it sits right over that LV outflow tract? When you're doing CPR, what's the goal? Where do you want the blood flow to go? Out of the heart, right? To the rest of the body. How does blood leave the heart? Through the outflow tract. So if you're doing CPR, but you're compressing right here, you're actually doing harm to the patient, because every time that you're pushing on the chest, you're blocking blood from getting out of the heart and you're causing it to go backwards the other way. So this is actually even less effective than not doing anything for the patient. If you're doing CPR and you have someone doing a transesophageal echo and they see this, they can tell you to move your hands towards the cardiac apex so that the compressions are happening down here instead of up here. So this is in real time, someone doing a transesophageal echo telling you to move your hands and finding the most effective place for your chest compressions to happen. You can see how when they compress at the cardiac apex, the aortic valve right here is opening up, indicating that you have positive blood flow going out to the rest of the body. This is probably, if you're going to take anything away from this talk for why TEEs are important in cardiac arrest, this is the most important thing. Then the next use for TEE in cardiac arrest is assessing for the cause of the arrest, or at least for reversible causes of the arrest. Here we utilize all 4 of these different views. And to understand what these are, I'll briefly touch on some basics of how the TEE probe works. So to start this, I want everyone to take your left hand, put it on your chest with your fingers facing out and your thumb out. So your hand is your TEE probe. The fingers are the ultrasound beams coming out of the probe and that's what's generating your picture. So what you're seeing on the screen is what your fingers are pointing at. The first maneuver you can do is advance or withdraw the probe. And all that is pushing the probe in or out of the esophagus. That just moves it up and down. So if you're too high and you can't see the heart, all you do is advance it and you eventually get down to the heart. If you're too low and the probe is down in the stomach, you withdraw it and it'll bring it back to the heart. The other thing you can do is twist the probe left and right. So if you still have your hand on your chest, that's just moving left and right, left and right. So you can imagine if you're looking here at 0 degrees, you can rotate the probe 180 degrees and look towards the back at the patient's spine. Wouldn't be very useful, but it's something you can do. Another thing that you can do with the probe is anteroflex and dorsiflex. And with your hand, this is simply flexing or extending the wrist. So instead of moving up or down, left or right, you're looking up or down like this. So you're not actually moving the probe, you're just changing the angle that the probe is looking. And then the last thing that you can do with the probe is actually twist it. So there's the crystals that actually generate the image sit in the head of the probe right here. And they generate that image that looks like your fingers coming out. And there's a little button on the probe that allows you to twist this. So not looking up or down, not looking left or right, you can actually twist the probe similar to kind of supinating or pronating your hand. You can go from 0 to 180 degrees. And if you go all the way over, all that does is flip the image on the screen. This is getting into the weeds a lot. You don't need to worry too much about all of this, but it helps kind of frame how to obtain these different views as I move forward. Okay, enough about that. When evaluating for the cause of cardiac arrest, it's helpful to know what each of these views is useful for looking at. The first one that you're going to get when you do a transesophageal echo is a mid-esophageal 4-chamber view. The reason that this is the first one is because you don't have to change the angle of the probe at all. All you do is put the probe down the esophagus until you see this view. And it's going to give you all 4 chambers of the heart. This is what it'll look like. Your probe is right here, and it's looking through the left atrium towards the rest of the heart. So you have the left atrium, the left ventricle, the right atrium, and the right ventricle. This is the first actual picture of a heart that you guys have seen on this presentation. So this is a normal heart. It's beating well, the valves are opening, everything seems to be moving appropriately. One of the things that this view is useful for in cardiac arrest is seeing if there's good organized cardiac activity. This is a patient where the cardiac activity is not as well structured and the heart isn't beating as well as the other one. So this is a patient with really bad heart failure. So they have congestive heart failure, and that might be the cause of their cardiac arrest. If you see this while you're doing CPR and someone checks for a pulse and they don't feel one, that might simply be because the blood pressure is too low for you to feel. And rather than doing more CPR, this patient might benefit from some inotropy like adrenaline or medications to make the heart beat better. I'm not suggesting that you stop CPR when you don't feel a pulse. You should still continue CPR, but as we start to get better at this, that's something that we can consider. We can also see pericardial effusions on this view. So this is the heart right here. Notice how the inside of the ventricles are kind of black, meaning that there's fluid in there or blood. And there's also this strip of black around it. That's fluid around the heart. And in the context of a cardiac arrest, this could indicate a pericardial effusion and cardiac tamponade as the cause of the arrest. And then because we're able to see all 4 chambers of the heart, this is also a very good view for evaluating for signs of right heart failure or right ventricular strain. You can sometimes also see blood clots on the right side of the heart, which could be indicative of a pulmonary embolism as the cause of the patient's heart failure or cardiac arrest. You can see here that the left ventricle appears to be beating pretty well, but the right side isn't moving very much. What we can do in these views is look at what's called the tricuspid annulus, which is this tissue on the tricuspid valve. And this is a surrogate for right ventricular function. The reason that we can use this to determine how well the right ventricle is beating is because the RV beats like a piston. It just moves in one plane, up and down like this, whereas the left ventricle, all walls move in. So because this isn't bouncing up and down, we know that this patient has RV strain and might have a pulmonary embolism. I know that can be a little bit hard to see, but compare that to the first picture we saw. See how the tricuspid valve is moving up and down very effectively, and this one's not moving much at all. So that's how you know this is right ventricular strain. This is a patient who might benefit from thrombolytics in the context of their cardiac arrest. The next view we get is the mid-esophageal long axis view, and we already talked about this one with evaluating for the effectiveness of chest compressions. To get this view, you don't actually have to move the probe at all. All you have to do is change the plane. So when you have your left hand on the chest again, you don't move up or down at all. You just change the plane from 0 to 150 degrees or so. And it'll get you a picture like this. And again, should recognize this from earlier in the talk, but we have the left atrium, the left ventricle, the aorta, and the right ventricle. This is mostly useful for evaluating for the effectiveness of chest compressions. This is the bicaval view. It's not particularly useful in a cardiac arrest outside of looking for an ECMO cannula being in the appropriate place, which I'll show a little bit later. But what you're seeing is the right atrium and the superior vena cava and the inferior vena cava draining into the right atrium. Sometimes in a cardiac arrest, you might see the superior vena cava being really collapsed where you can't really see it, which could indicate hypovolemia or hemorrhage in the appropriate patient. And that could be a cause of cardiac arrest. But in general, this view is not going to be the most useful. And then the last view we obtain is the only one where we actually have to move the probe. This is the transgastric short axis view. So from all of our mid-esophageal views to obtain this one, you just push the probe in a little bit farther down into the stomach, and then you anteroflex it so that it looks up through the stomach into the heart. And what you're seeing is a short axis cut through the left ventricle. And we can see all the different walls of the heart here. What I want to highlight on this picture is notice how all 4 of these walls seem to be coming into the middle about the same. If you look at how much they're moving towards my laser pointer, everything's moving about the same effectiveness. If you compare that to this picture, I put my laser pointer back in the middle, you can see that some of the walls aren't really moving that well. The septal wall is coming in pretty well, but the lateral wall isn't moving much. The anterior wall isn't moving much. Even the inferior wall is not moving very much. The reason that we like this view in a cardiac arrest is because you can see these wall motion abnormalities where parts of the heart aren't moving as well as the rest of it. And that can be indicative of a myocardial infarction or a heart attack. In this patient, you can actually even predict where their heart attack is because of what walls aren't moving. When you have a lateral and anterior wall infarct, you're concerned about a left anterior descending artery occlusion. And because the inferior wall is involved as well, this might even be a left coronary artery lesion. And then lastly, beyond the benefits of looking for causes of cardiac arrest and evaluating the effectiveness of our chest compressions, the other thing that we use transesophageal echo for in a cardiac arrest is evaluating for the appropriate placement of an ECMO cannula. The ECMO cannula will be coming from the right groin, and it'll eventually place through the IVC, and you want to see it into the right atrium so that it can pull out all of the blood on the venous side and send it through the ECMO circuit so that it can be oxygenated and then put back into systemic circulation. So I know that's a lot of information. TEE is an incredible tool. It's being shown to be very effective in guiding our resuscitations and making them more effective, but it's still not widely available in most emergency departments. Not really available in the pre-hospital setting right now. But as more evidence shows that this resuscitative TEE directly improves our resuscitative outcomes, I think this is going to start to become more of the standard of care, particularly for evaluating for the effectiveness of chest compressions. Because if you're doing early CPR, it doesn't really matter if you're doing it inappropriately. And TEE is going to be able to help to make sure that all CPR is done better and most effectively. So I'll hand it back to Dr. Acker.
Fantastic. So clearly, there's so many ways that technology can help patients who are suffering from cardiac arrest. From early detection, prompt and effective CPR, decreasing time to fibrillation, use of EMS, and then also these advanced resuscitative techniques. There's also a couple other exciting opportunities for technology to help. And I think these ones are really focused on access. How do we provide access to good care for our patients? And that is so much of what your job is helping connect patients with the care they need. So we'll look at a couple of examples. And I think one of the most obvious ones is telemedicine. I think telemedicine is something that's been around for a while, but I feel like we all finally saw the benefit of during the COVID pandemic. And we've now been forced to be more creative with how we use it. And it's been shown to be really helpful for prenatal care, high-risk obstetric monitoring, pre-referral triage. There's so many places where this can be helpful, and it helps us bring care to areas that are remote or where providers are lacking, offering all sorts of input that can help benefit the patient. It's also becoming easier because technology is cheaper and more effective. I mean, most of us have cell phones that can do this. There's new modules that can help spread this care a little bit more broadly. People have also been using artificial intelligence to help improve the patient's ability to get the right care at the right place. So we now have tools that can use data and artificial intelligence to help determine what patients need to go to what types of facilities. Trauma triage, critical care triage, some obstetric care triage, to help make sure patients are going to the right hospitals. One of the ones that I found most interesting was similar to the prior example, drone delivery of supplies. So just like we saw before, here's an unmanned vehicle, and they're dropping blood products to hospitals in rural Rwanda. So a company called Zipline has started building drones. I think there's actually some pilot projects happening in India. But in Rwanda, they showed they were able to successfully deliver drugs and blood products, reducing stockouts. So they improved facilities' ability to have these medicines on and blood on hand. The average time delivery was about 50 minutes, which is not too bad. And it was so much faster than road delivery. So it beat road delivery by over an hour. And it reduced the amount of blood products that were expiring by about 70%. So there's so many parts of India in which blood products and certain medications are hard to come by. Can you imagine if a bleeding postpartum hemorrhage patient was able to get blood within 49 minutes to a rural hospital that they currently don't have blood? You can imagine this could potentially save a lot of lives. The last exciting item I want to mention that Dr. Lanter is going to tell you a little more about is handheld ultrasound devices.
But you guys got rid of me, didn't you? So handheld devices, kind of staying in the ultrasound category, which is my lane, refer to small portable ultrasound devices, which can be used in a lot of different settings that normally didn't previously have access. A lot of different companies are making these right now. This is kind of the general premise. And the idea is they can inexpensively make these small probes that then hook into a cell phone or a tablet, which basically everybody has access to now, and provide actual ultrasound technology to be used for patients in settings where they previously weren't used. This is a GEV scan, which is just another one of these products. It has two probes on it, so there's one here and one here, so it's a little bit more versatile. And what's really cool and exciting about these devices is they are not only able to be used in hospitals across the hospital, so the ORs, the emergency room, the floors, clinics, they can also be used in the pre-hospital setting. This is actually something that started to happen in the United States. This is a butterfly probe, and they're kind of the pioneers for these handheld devices. Like I said, pretty much everyone is making them now, but butterfly was the first one to be used. And what's cool about butterfly and the reason I want to highlight them is because they are the most inexpensive of all ultrasound devices right now, because they utilize a microchip inside to actually make their images rather than the crystals, which are used in all other ultrasound devices. It makes the images a little bit, lower quality, but it makes the probe significantly more accessible. And it also makes them more versatile because it's a microchip instead of fixed crystals. These can be used for pretty much everything you would need an ultrasound for. And kind of while we're taking questions, I actually have one of these. So I'm gonna pass this around while we're taking questions, so you guys can all kind of play with it, look on your arms, look for veins, look at the muscles and everything, and just kind of see what an ultrasound is. I could go on and on regarding how ultrasound will continue to change our everyday practice. Suffice it to say that point of care ultrasound is continuing to evolve to be more useful and in more situations with more accessibility. And we're closer than ever to every single healthcare provider being able to have one of these in their pocket, similar to how people carry a stethoscope, and being able to use it for their patients, like in every healthcare encounter. So I'm gonna get this set up and start passing it around if you want me. Also, this is my cell phone, so please don't break it.
Thank you, Dr. Lanter. Yes, I think there's so many exciting ways that technology is helping increase access to expertise, getting patients to the right place, increasing access to supplies and imaging, as we just saw with these ultrasounds. And I think going into the future, technology is going to be utilized to improve our recognition of emergencies, reduce time to critical interventions, enhance our access to expertise in care, and really broaden our access to essential interventions, medications, and blood. So I think with this technology, this is a time to be bold and creative. You saw all these solutions were new ideas, linking technologies with problems that we currently have. And I think that as we go forward, we're going to be doing more and more of this. So I'll leave you with that note. I'd love any questions you have. Thank you so much for having us today. Are there any questions we can answer? Yes, sir.
The ultrasound which you have shown, do you have the FDA approval for that?
I believe it is approved in India. I have to confirm that though. FDA, yes, sorry, it is FDA approved. The only indication that it's not approved for is ocular ultrasound, because it gets a little bit warmer than the other types of ultrasounds. And there's a theoretical risk of thermal damage to the retina. But all the other handheld devices are FDA approved for every indication.
The other thing is, you told about I think of the drain, dropping of the AED from the drain. What is the distance? 9 meters. Are there any studies which show that if this drop from 9 meters, there won't be any damage to the
Excellent question. So I think the 9 meters were referring to a radius distance from a circuit point. So I believe that the AED is being dropped on a rope, so it's slowly lowered. So I think it reduces the risk of damage to the AED, but I haven't seen data in terms of like, could you damage it dropping it? That's a really good question.
Sorry, one more last question.
Please.
Echo, which you code, not echo, EED, is raised. There is a figure, and they're doing the chest compression. Will it be an effective CPR?
It doesn't have a negative effect, if that's what you mean. There is a potential iatrogenic injury to the esophagus that's been shown, but that's mostly in the actual placement. So it's in the upper esophagus, not in the lower. And the percentages are, I don't remember the exact numbers, but it's below 5% of any sort of iatrogenic injury. And as far as if it affects the CPR at all, the only evidence that's there is that it significantly improves CPR, and that I think that's mostly because of the appropriate hand placement. So if there's any negative effects, I think that they're very outweighed by that. But I'm not familiar with any real kind of theory on if it would negatively impact CPR.
Thank you very much and congratulations for what you have done. Wonderful presentation. One thing I wanted to add is for the outcome of the cardiac arrest. Here in India, we are doing PCR, telephonic CPR.
Oh, wonderful.
So that maybe you can add one more thing.
Yeah.
That is giving a, that should give a lot of awareness because telephonic CPR, once they call the call center, they will be telling about what they have to do.
I'm gonna add that. That's another technology intervention. That's fantastic. Thank you for that. Any other questions from? Yes, sir.
What are the contraindications for transesophageal when addressing it in close?
To my knowledge, the only contraindication is known anatomic abnormalities of the esophagus. In the context of cardiac arrest, I don't believe that there's any situation where you would directly not be able to place it.
Is there another question over in this area?
So I have a question.
Okay. Please go ahead. Oh, yes, sir.
Can I do full body checkup?
What's that?
Full body checkup.
Check any part of the body.
Yeah.
They need to know what you're looking for.
Yeah, the butterfly, you can look at the heart, the kidneys, the gallbladder, you can look at the lungs, you can look at the thyroid. If you have a body part, you can ultrasound. It's my theory.
Any other questions? That's a good one.
Cool. Well, thank you all. Appreciate you being such a good audience.
Did you have one more question, sir? And he's at, all right. All right, well, thank you so much. We appreciate your time. Thank you. Thank you for your hard work. Oh, is there any questions in the chat? Oh, that's so nice.
From my side also, I want to thank the Stanford team, Dr. Acker and then Dr. Lanter for telling us, how we can stretch our imagination and bring more survival rates to the cardiac arrest situation. In the next few minutes, I just wanted to share with you what we have been trying to do in certain pockets of India under EMRI. We are trying to do in certain situations. We have done the proof of concept, but we are yet to expand it to the other states. We had a fund from Asian Association of EMS, and under that grant called PAROS, Pan Asian Resuscitation Outcome Studies, 2018 and 19, right? 2016 to 19. There is one initiative at the global level called Global Resuscitation Alliance, right? All of this, if you Google, you will get everything there. Under the Global Resuscitation Alliance, the concept is we have level 1 evidence how to overcome the problem of sudden cardiac arrest by the chain of survival. I'm sure many of us are aware of that. That early recognition, early initiation of CPR, early AED, and rest of the things to the transportation and advanced life support. So Global Resuscitation Alliance says that in spite of having a very good evidence, in spite of having a very good training programs, in many parts of the world, the sudden cardiac arrest outcomes have not gone beyond 10%. I had an opportunity to be there in 2 global conferences. Dr. Raja has also participated in 2 global conferences. Now there is one resuscitation academy with which we are associated. We is as an EMRI. And in that, we have realized that after having a sudden cardiac arrest data, which we said that in India, the sudden cardiac arrests are about 1.2 millions, while Dr. Peter Acker was mentioning about 500,000. And then with our collaboration with other senior people who are all involved, our guesstimate of sudden cardiac arrest in India are about 1.2 million at this point of time. We do not have the public access defibrillator, as he was mentioning that we have to depend only on the hands alone CPR. He has also mentioned, and a multi-centric study in India said that if in India anybody has an emergency, including sudden cardiac arrest, the chances of getting a help, I'm using the word quote unquote good Samaritan, is 7%, right? He was also mentioning to the same percentage, about 8%. These are all multi-centric studies, which are all Indian studies. And our studies have also shown that 7 out of 10 are witnessed cardiac arrest, and then most of them, they happen within the family, workplace, or on the road. Because our density of population is more, and then हम लोग अकेला बहुत कम रहते, right? कोई ना कोई होते रहते, right? आस-पास में, right? What we have done, keeping all of these situations, globally it is called dispatcher assistance CPR, but in India we are very much used to this word telephone, right? So we have used a word called telephone CPR. In our own emergency response center, at that time we used to have a technology partner. So we used to ask, the ERO used to ask, no breathing, no pulse. These are the two parts, right? No breathing, no pulse. Then the ERO takes it for granted that it is a case of a sudden cardiac arrest. Even if it is a doubtful sudden cardiac arrest also, somebody does a CPR, there's not much damage according to the scientific studies. So once a CPR is identified and a family member is there, then we have used this instructional CPR. So we have created several steps and we have converted into several Indian languages. We have taken into consideration the cultural factors and we found several challenges, right? How to place the person in a place where there is a hard background. Say, for example, if somebody is on the bed, how to bring him to the ground level was one challenge. In this very hall, I think a few of us are already here. So we also found that by speaking to somebody, how to ensure that the hands are correctly placed for starting the CPR. That was our major challenge, another major challenge, right? And then we had challenges with the speed, the fastness, and of course, the depth of this. However, in spite of all these challenges, we used to have a telephone CPR desk in our ERC, and successfully, we have addressed about 150 or so sudden cardiac arrests. And then our survival rates have become little significant, right? I will not be able to give you all those numbers, but I just want to tell you that we have used this technique of telephone CPR. We have implemented it and we wanted to start in Gujarat and Tamil Nadu, but at that time there were some challenges. This is one area which I wanted to tell you. This is a published data. Anybody you can write, you can Google telephone CPR, GVK EMRI, and then that data, that paper is there, right? We have worked with one Professor Michael Best from Norway, and then it was published because he's a global guru for telephone CPR. He has done about 50 papers only on telephone CPR. So that is one contribution. But why I'm trying to tell you is that soon EMRI is going to the next level of technology, and we will be definitely be able to implement this telephone CPR, including Dr. Raja says that we should do it in all the hospitals. Why confined to only 108? Because hospitals will, somebody will call that somebody in my house is sick, please send an ambulance, send a doctor. Now that connectivity is also happening, and I'm sure that down the line we'll be able to do this. The second area where I just want to tell you that we know that 40% of the road accident deaths are because of hemorrhage, and bleeding can be controlled by very simple techniques like pressure bandage and using a tourniquet. And we also have a hemostatic pads, right, which are all having a chitin, right, as a chemical, if I remember that word correctly, right. So in this side, 25 kilometers, on the other side, we call it NH44 and State Highway 1. We have trained about 1,100 auto drivers, bus drivers, students, and we have given them a kit called active bleeding control kit. And in this, on that study period of about, say, 1.5 years, in the phase 1, our volunteers of ABC were able to attend to about 57 emergency cases, and we are very proud to say that it is also published data, and then it went off very well. And now the ABC movement, active bleeding control movement, is now being put into the Hyderabad schools. About 14,000 school children are trained on this. In Bangalore, we have been working with St. John's organization, and I also had an opportunity there in Ramaya Medical College, MS Ramaya Medical College, and we brought it to the notice of the government of India also, this ABC. And in the phase 2 of the ABC, we have been working with Indian Institute of Sciences, Bangalore, and because this is a very safe zone where our Kompally EMRI head office, so Air Force authorities did not permit us. So we have demonstrated the use of drone and dropping the active bleeding control, right? We must be having those brief videos also with some of us, Mr. Madhusudan, Devender, they were all colleagues of us, they were involved with that. So we have done it very, very successfully, leveraging the technology. But I'm standing in front of you to tell you this thing. मैं हिंदी में बताना चाहता हूँ कि हम लोग उत्तर प्रदेश में थोड़ा को आगे बढ़ाए थे। जैसे हमारे 108 के सेंटर से जब भी कॉल आएंगे ना, हम लोग 2 चीज पहले तय करेंगे। एक, कौन सा एम्बुलेंस इमरजेंसी को भेजना चाहिए, क्योंकि तो हम लोगों को लोकेशन बेस्ड सर्विसेज LBS हम लोगों का मौजूदा है, राइट। एक कौन सा गली में कौन सा मकान से एक कॉल आ रहा है, हम लोगों को मालूम हो रहा है। इसकी वजह से हम लोग नजदीक जो भी एम्बुलेंस है उसको हम लोग इंस्ट्रक्शन देते, एंड 30 सेकंड्स के अंदर उत्तर प्रदेश राज्य में अभी एम्बुलेंस मूव हुआ नहीं हुआ टुवर्ड्स द लोकेशन, वी विल नो बाय जीपीएस। जीपीएस की जो जियो स्पेशल जो भी होता है, उससे मालूम होता है कि एम्बुलेंस स्टार्ट हुआ नहीं हुआ। एंड देन वी हैव आल्सो, इसके साथ में हम लोग इंसिडेंट लोकेशन के, अगर आजू बाजू में गए तो हम लोग, और एक दायर में हम लोगों को मालूम होता है कि एम्बुलेंस हमारे इंसिडेंट लोकेशन पे आ गए। सो टेक्नोलॉजी के इस्तेमाल करते हुए हम लोग ऐसी, और हम लोग हॉस्पिटल की तरफ सीन में केयर करने के बाद हम लोग रोड एंड गो सिस्टम यूज करते हैं। और हॉस्पिटल की जब हम लोग एम्बुलेंस को दौड़ाते हैं, वो टाइम पे हम लोग एक्सपेक्टेड टाइम ऑफ अराइवल और पेशेंट की जो भी सिंपल इंफॉर्मेशन, नाम क्या है, जेंडर क्या है, एज क्या है, उसका वाइटल्स क्या है, एंड व्हाट इज द सब टाइप ऑफ इमरजेंसी, हम लोग अस्पताल तक पहुंचा रहे हैं। मखसूस तेलंगाना राज्य में अगर 6 महीने के बाद में अगर मैं आपके सामने खड़ा रहा तो हॉस्पिटल वाले को किस तरफ से एम्बुलेंस आ रहा है, कितने मिनट में एम्बुलेंस आ रहा है, उसका पेशेंट की वाइटल्स क्या होता है, राइट। हर एम्बुलेंस में हमने 2 कैमरा लगा रहे हैं, राइट। अगर डॉक्टर साहब यहाँ की जो बैठते हैं ERC फिजिशियन, अगर उसको चाहते हो उसको जूम करके पेशेंट की जो कियाफा कैसा है, यू नो, इज इन पेशेंट इज इन शॉक, और इज द CPR इज बीइंग डन इन अ गुड क्वालिटी, हाई परफॉर्मेंस CPR चल रहा है नहीं चल रहा है। हम लोग 6 महीने के बाद एज हमारे इसमें हम लोगों को मालूम हो सकता है। ERC से भी हम लोग पूरा तैयारी कर रहा है, राइट। और लास्ट पॉइंट आई जस्ट वांट टू टेल यू दैट इंटरनेट ऑफ थिंग्स राइट। बहुत लोगों को मालूम है कि हमारे हिंदुस्तान में भी 5G का भी आ गया राइट, दौरा आ गया राइट। हम लोग जियो वाले को बुलाया, एयरटेल वाले को बुलाया और 2-3 जो टेलीकॉम प्रोवाइडर्स होते हैं उन्होंने उनसे बुलाया और हम लोग थोड़ा एक्सपेरिमेंट भी कर रहे हैं। ECG मल्टीपैरामीटर मॉनिटर जो भी हमारे एम्बुलेंस में है उसको इंफॉर्मेशन हम लोग एक स्क्रीन पे लगा के डॉक्टर को, हमारे यहाँ पर जो ERC होते हैं और अस्पताल के जो डॉक्टर को, दोनों पर हम लोग भेजना चाहते हैं। हम लोग थोड़ा बहुत एक्सपेरिमेंट कर चुके हैं। मेरे को ये मालूम हुआ कि 5G की जरूरत है, 4G से भी 4G से भी ये हो सकता है। इसकी वजह से बोल रहा हूँ कि 1 साल के अंदर ये सब हम लोग, जब आप यहाँ पर ट्रेनिंग में है, हमारे जो फिजिकल 2 ईयर के वाले ट्रेनिंग में अगर आप जाते हुए, आई एम श्योर दैट विल बी हैपनिंग नियर 99% ऑफ द टाइम्स। एंड सो टेक्नोलॉजी की जो EMRI itself is a technology centered approach, and what our senior colleagues from Stanford have mentioned, I'm very sure that we are very, very close to that, right? So we will definitely be working on the electronic PCR also with these people. If there is an emergency, right? Head injury ka samjho hai samjho, right? So we have been working with the Stanford team, Dr. Apurva. What kind of alerts EMT should get? अरे cervical collar लगाया क्या, right? मैं तो hypoxia हो रहा है क्या, right? ऐसा या hypotension अब हुआ तो IV fluid का हम लोग एक SMS alert भेजना चाहते हैं, right? ना जैसे cardiac arrest है, मगर बाकी जो emergencies में भी हम लोग जैसे oxytocin का हम लोग सोच रहे हैं, right? Yeah, about 30 emergencies and about 35 to 40 alerts. We want to see that the EMTs get, so that we are doing a better quality of services. आज जो कर रहे हैं उससे अच्छा हम लोग तरक्की और quality of care भी अच्छा हो, and it is documented, it is being done while on real time basis. हम लोगों का बहुत energy के साथ इस तरफ हम लोग कोशिश कर रहे हैं. I wish and I pray that we are all successful, and then on this day, I'm making a statement that all of us who are all sitting there and committed to the pre-hospital care, I think will be the best beneficiaries of technology. And then what both these doctors from Stanford have mentioned to us, that it is going to be very revolutionary. And then many of the things they have said, I think we should be able to ground them not in the dreams also. I just wanted to thank you for your active listening to this and paying attention to that. Thank you.
Thank you, everyone. So thank you, Team Stanford. One more round of big applause, please. I think we initially missed Dr. Krishnaraj, sir, who came in between. So we thank you for attending the session as well, sir. And thank you once again, everyone, for attending the session. Thank you, all our instructors. We'll go out and have a group photo as well. And before we disperse, thank you.